Welcome to the deep dive. Today, we're embarking on a really fascinating journey. We're going deep into the core concepts of psychobiology and psychopharmacology. We're distilling the absolute essentials from key texts, like your Varkarolis textbook, our mission, to
Mhm.
basically give you a shortcut, maybe even a cheat code, to really get how the brain works, what happens when its rhythm is off, and how psychiatric medications actually step in to help manage things.
Exactly. And this isn't just about rote memorization of drug names or mechanisms. It's really about understanding that every single patient interaction, every medication choice you're involved with, it's all tied to the brain's really delicate chemistry. We want to help you anticipate the effects, the nuances of these pretty powerful tools to really get the why behind the what, and then apply that knowledge directly in your clinical settings. And yeah, even for those critical NCLEX questions, we'll be breaking down the complex terms using real-world examples so you can build both that solid knowledge base and, just as importantly, empathy.
All right, sounds great. Let's start right at the beginning then. The incredible human brain. It's so much more than just a thinking machine, isn't it? It's like the ultimate coordinator for almost everything our body does. A lot of it happens without us even noticing.
That's so true. Think of it as like your body's central command. It's constantly monitoring, constantly directing traffic, maintaining basic homeostasis, regulating heart rate, blood pressure, body temperature with amazing precision. It also controls those fundamental biological drives, hunger, thirst, sex drive. And it even orchestrates our sleep-wake cycles, our circadian rhythms, which, by the way, disturbances in those rhythms. You see that a lot in mood disorders. It's often a key feature.
Right. And beyond just keeping the lights on, biologically speaking, it's where our conscious mental activity happens, memory formation, and how that can be so tragically affected, like in Alzheimer's, where short-term memory might fade drastically, but really old memories can stay sharp. And of course, all those social skills that let us connect with each other. But how does this all work on a microscopic level? Let's talk neurons, the brain's messengers. What are these tiny powerhouses actually doing?
Okay, yeah. Neurons are the real workhorses here. They're constantly responding to stimuli. They generate and conduct these little electrical impulses. Think of them like tiny electrical surges. This happens through really rapid, precise movements of charged particles, primarily sodium ions flowing in and potassium ions flowing out. Then, and this is crucial, when that electrical signal hits the end of the neuron, it triggers the release of chemical messengers. We call them neurotransmitters. These neurotransmitters jump across a tiny gap, that's the synapse, and they bind to specific docking stations or receptors on the next neuron in line. And that binding action either excites the next neuron, tells it to fire, or it inhibits it, tells it not to fire. This whole interaction, this chemical conversation between neurons, that's the primary target for almost all psychiatric medications.
Chemical conversation. I like that. And the brain isn't just a random jumble of these conversations, right? It's highly organized. Can you give us a quick sort of geographical tour, the main areas and what they do?
Absolutely. We can kind of think about it in layers, from the, let's say, more primitive parts up to the highly evolved ones. So down at the base, you've got the brainstem. That handles the really vital life-sustaining stuff, breathing, heart rate, keeping us conscious. Just above that, kind of tucked away, is the hypothalamus. Tiny structure, but incredibly powerful. It regulates basic drives, hunger, thirst, sex, and it acts as this crucial bridge, linking brain activity with our internal organs and hormones. A really key example here is the HPA axis, the hypothalamic pituitary adrenal axis. That's central to our stress response. And in conditions like depression, it can get seriously dysregulated, leading to constantly high stress hormone levels.
Okay, the HPA axis, right?
Then you've got the cerebellum, sort of nestled at the back. That's vital for coordinated movement, balance. And then the big one, the cerebrum, the largest part. That's where our conscious perception, our emotions, memory, language, all of that higher level stuff happens. And deep within the cerebrum, there's a really key network for mental health, the limbic system. This involves structures you might have heard of, like the amygdala and hippocampus. It's heavily involved in our emotional status, in memory formation, and it relies a lot on neurotransmitters like norepinephrine, serotonin, and dopamine. What's really fascinating and important clinically is how interconnected all these brain areas are, which is why a drug designed to affect, say, serotonin in one area can sometimes cause side effects related to movement or sleep or appetite. It shows just how networked the whole system is.
So if we can't actually see these microscopic chemical chats happening, how do researchers and clinicians get a window into what's going on? How do we visualize brain activity?
Yeah, good question. That's where brain imaging technology is so valuable. We have structural techniques first, like CT scans and MRI. These give us detailed, static pictures of the brain's anatomy. They help us spot physical issues, maybe tumor or damage from a stroke, that kind of thing. Then there are the functional techniques like PET scans and SPECT. These let us see the brain in action. PET scans, for instance, use a radioactive form of glucose, the brain's main fuel. They show metabolic activity. Basically, they light up the areas of the brain that are working hardest, using the most fuel.
So you can actually see which parts are more or less active.
Exactly. Imagine a PET scan of a healthy brain. You'd see vibrant activity, lots of glucose uptake, especially in the frontal lobes, which are key for reasoning. Now, contrast that with a scan, maybe from someone with schizophrenia who isn't medicated. You might see noticeably decreased glucose use in those same frontal lobes, like dimmer lights almost. And that aligns with the difficulties in reasoning and executive function often seen in the disorder. Similarly, in depression, PEC scans often show reduced brain activity, particularly in the prefrontal cortex. And for Alzheimer's, you see characteristic patterns of reduced metabolism in temporal and parietal regions, areas crucial for memory and spatial awareness. These tools aren't just cool tech, they really help us understand which brain areas are involved in dysfunction and potentially how drugs might be targeting those areas.
Okay, so that paints a picture of the normal, incredibly complex operation. What happens when things go wrong? What do we know about the causes of mental dysfunction? What's still a mystery?
Well, the honest answer is that the precise origins of many mental health disorders are still not fully understood. It's a huge area of ongoing research. But we do know that it's usually a combination of factors. Genetics definitely plays a role. Exposure to certain drugs or toxins can be involved. Infections, physical trauma. Take genetics, for example. There's a clear genetic predisposition for many psychiatric disorders. With schizophrenia, if you look at identical twins who share 100% of their genes, there's about a 50% concordance rate, meaning if one twin has it, the other has a 50% chance of developing it too, even if they're raised in different environments.
Wow, 50%. So genetics is a big piece, but not the whole story.
Exactly. It tells us genetics is significant, but clearly other factors, environmental triggers, developmental experiences, are also profoundly involved in whether a disorder actually manifests. But a really major player in the brain's chemical stew, and often right at the root of psychiatric illness, are those neurotransmitters we talked about. Alterations in their balance, how much is released, how well the receptors respond. These are the primary targets for most psychotropic medications.
That's fascinating how specific these imbalances can be. Can you give us some key examples? How might neurotransmitter issues show up in common conditions?
Sure. Let's take major depression. The leading hypothesis, the monoamine hypothesis, suggests there's often a deficiency in key neurotransmitters, like norepinephrine, serotonin, or maybe dopamine. This deficiency could be because not enough neurotransmitters are being released into the synapse. Or maybe enough is released, but the postsynaptic receptors aren't responding properly, they're less sensitive. Now flip that. In thought disorders like schizophrenia, the issue seems to be an excess of dopamine transmission. Either too much dopamine is being released, or the receptors are overly responsive.
So too little in one case, too much in another. It's all about balance.
Precisely. It's this incredibly delicate balance. And for anxiety disorders, we often see insufficient activity of GABA, the inhibitory neurotransmitter. GABA acts like the brain's brake pedal. If there's not enough braking action, the system can become overstimulated, leading to anxiety symptoms.
It's easy to see how that affects thinking and mood. But you mentioned earlier these imbalances can also impact basic body processes. That seems like a really crucial connection for nurses to grasp.
Absolutely critical. Think about dopamine again. It's deeply involved in regulating movement in addition to thought processes. So if dopamine levels are altered, either by the illness itself or by medications blocking dopamine receptors, you can see effects on movement, things like tremors, muscle stiffness, or even difficulty initiating movement. Parkinsonism-like symptoms. This is why you often see changes in sleep patterns, body movement, even autonomic functions like heart rate or digestion, both as part of the mental disturbance itself and as side effects of the medications used to treat it. It really underscores how the brain influences the entire body.
Okay, that makes sense. Now let's pivot to the medications themselves. How do psychotropic drugs actually aim to turn these imbalances back toward a healthier state? What are the core concepts we absolutely need to understand?
Right, to really get how these drugs work, we need to look at two key concepts, pharmacodynamics and pharmacokinetics. Pharmacodynamics is basically what the drug does to the body and how it does it, its actions, its effects, and these are always related to the dose. More drug, usually more effect up to a point. Pharmacokinetics, on the other hand, is what the body does to the drug. It's all about the movement of the drug through the body. There's a handy acronym for this, ADME. Absorption, distribution, metabolism, and excretion. So absorption is how the drug gets from where it's administered, say, orally into the bloodstream. Distribution is how it spreads from the blood out into the tissues and eventually reaches its target site, like specific receptors in the brain. Metabolism is how the drug gets chemically changed, usually by enzymes in the liver. Sometimes it's broken down into inactive forms, but sometimes it's converted into active metabolites that also have effects. And finally, excretion is how the body gets rid of the drug and its metabolites, most often through the kidneys and urine. Understanding ADME is absolutely vital for nurses. It directly impacts choices about the best route of administration, the right dosage, the timing, or schedule, all aimed at maximizing the benefit for the patient while minimizing potential harm. For example, if you know your patient has impaired liver function, you immediately think, okay, their metabolism of certain drugs might be slower, which could lead to higher drug levels and increased risk of side effects if the dose isn't adjusted.
And it's getting even more specific now, isn't it? We're learning that how a drug moves through my body versus your body can be really different based on our genes.
It's exactly. That's pharmacogenetics, and is becoming increasingly important in psychiatric nursing. It explains how variations in our genes, particularly those liver enzymes we mentioned, the cytochrome P450 or CYP enzymes, which metabolize most psychotropics, how those variations lead to significant differences in how people tolerate and respond to drugs. This varies across individuals and even across different ethnic groups. For instance, there's a specific enzyme, CYP2C19. About 20% of certain Asian subgroups are known to be poor metabolizers for this enzyme. That means they break down drugs handled by CYP2C19 much more slowly than average, so a standard dose for them might act like a very light dose, increasing their risk for side effects.
Wow. And there's specific clinical examples of this we need to know.
Absolutely, and this is a critical one, truly important for your exams and your practice. It involves the drug carbamazepine. Carbamazepine is an anticonvulsant, often used as a mood stabilizer, particularly in bipolar disorder. But individuals of Asian and Southern Asian Indian ancestry who carry a specific genetic marker, an allele called HLA-B5002, have a much, much higher risk of developing incredibly dangerous skin reactions, like Stevens-Johnson syndrome or toxic epidermal necrolysis when they take carbamazepine. These are severe, potentially fatal conditions. Because of this risk, the FDA actually recommends genetic screening for this HLA-B502 allele before starting carbamazepine in patients from these populations. This really highlights the critical importance of cultural competence and patient advocacy. Knowing about these potential genetic differences helps you provide safer, more tailored care.
That's a powerful example. Okay, one more foundational piece before we jump into specific drug classes. Agonists versus antagonists. Can you quickly break those down?
Sure, think of it like keys and locks. An agonist drug is like a master key. It binds to a receptor site and stimulates it, mimicking the effect of the body's natural neurotransmitter. It turns the lock and opens the door, increasing the activity of that system. An antagonist drug, on the other hand, is like a key that fits in the lock but won't turn. It binds to the receptor site but blocks it. It prevents the natural neurotransmitter from binding and activating the receptor, so it obstructs the action, effectively decreasing the activity of that system. Most psychotropic drugs work in one of these two fundamental ways, either boosting or blocking the activity of specific neurotransmitter systems.
Perfect. Agonist mimics, antagonist blocks.
Got it.
Okay, with that foundation laid, let's get into the specifics. The pharmacological toolkit. What are the key drug classes that you, as future nurses, are going to see all the time? And what are the absolute must-know nursing implications for each?
All right, let's start with anti-anxiety and hypnotic drugs. Probably the most common anti-anxiety agents are the benzodiazepines. Drugs like diazepam, lorazepam, alprazolam, you'll see these a lot. Brand names like Valium, Ativan, Xanax. They work by enhancing the effect of GABA, that inhibitory neurotransmitter we talked about. Basically, they help the brain's brake pedal work better, leading to a calming effect. But, and this is a big but, they come with significant risks. Sedation, drowsiness, ataxia that's impaired coordination, unsteadiness, and impaired judgment.
And the big danger is mixing them, right?
Absolutely critical safety point. When benzodiazepines are combined with other central nervous system depressants, things like alcohol, opioids, even some older antidepressants like TCAs, or even some antihistamines, their inhibitory effects add up. This combination can be life-threatening because it can lead to severe respiratory depression, slowed or stopped breathing. As a nurse, you have to emphasize this danger. You'll constantly be cautioning patients against activities that require alertness, like driving or operating heavy machinery. And you need to be super vigilant about fall risk, especially in older adults, because of that potential for ataxia and sedation. Other options in this category include the Z-hypnotics like zolpidem, Ambien. They're more selective for sleep, but they can still cause side effects like amnesia, people doing things while asleep and not remembering, and ataxia. The key instruction is only take them when you are ready to get into bed and stay there. There are newer agents too, like suvorexant, Bilsomra, which works differently by blocking orexin receptors involved in wakefulness, but it carries warnings about potential increases in suicidal thoughts. And then there's buspirone, Buspar. It's interesting because it reduces anxiety, likely through effects on serotonin, but without the strong sedative or addictive properties of benzodiazepines. So it can be a better option for some, especially those with substance use history or who need to stay alert.
Okay, that covers anxiety and sleep meds. What about antidepressant drugs?
So antidepressants mostly work by increasing the levels of key neurotransmitters, particularly serotonin and better norepinephrine, in the synapse. This fits with the monoamine hypothesis of depression we mentioned earlier. The most commonly prescribed class now are the SSRIs, selective serotonin reuptake inhibitors. Drugs like fluoxetine, Prozac, sertraline, Zoloft, escitalopram, Lexapro. They work by specifically blocking the reuptake pump for serotonin. This means more serotonin stays in the synapse longer, available to bind to receptors. They're often first line because they're generally safer in overdose than older antidepressants and have a relatively tolerable side effect profile for many people. That said, common side effects you need to educate patients about include sexual dysfunction, sometimes apathy or emotional blunting, and often GI disturbances like nausea, especially when starting.
And there are other classes beyond SSRIs.
Oh yes, you have SNRIs, serotonin norepinephrine reuptake inhibitors, like venlafaxine, Effexor, and duloxetine, Cymbalta. As the name implies, they block reuptake of both serotonin and norepinephrine. They can sometimes be more effective, especially for certain types of depression or pain syndromes, but they also carry a risk of increasing blood pressure, so that needs monitoring. Then there are NDRIs, norepinephrine dopamine reuptake inhibitors. The main one here is bupropion, Butrin. Bupropion is unique. It doesn't have the sexual side effects common with SNAS, NIS, which is a big plus for some patients. It's also used to help people quit smoking under the name Zybin. But, and this is a huge NCLEX point and safety issue, bupropion lowers the seizure threshold. So it is absolutely contraindicated, meaning do not give it to patients with a seizure disorder or a history of eating disorders like bulimia or anorexia, because those conditions also increase seizure risk.
Okay, bupropion and seizure risk. Got it. What about the older ones?
Right, the older classes. First, the TCAs, tricyclic antidepressants, drugs like amitriptyline and nortriptyline. They were among the first antidepressants developed and are still effective, but they have more side effects. They block reuptake of norepinephrine and serotonin, but they also hit other receptors, leading to anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention plus sedation, and potential orthostatic hypotension, dizziness on standing. And here's the critical safety concern with TCAs. They are much more lethal in overdose than SSRIs. Overdoses can cause severe cardiac conduction disturbances, leading to arrhythmias and death. So you have to be incredibly careful prescribing these for patients who might be at risk for suicide. A small overdose can be fatal.
That's a really serious consideration. And the last antidepressant class?
The MAOI's monoamine oxidase inhibitors, like phenelzine, Nardil, tranylcypromine, Parnate. These work differently. They inhibit the enzyme monoamine oxidase, which is responsible for breaking down neurotransmitters like norepinephrine, serotonin, and dopamine inside the neuron. By inhibiting this enzyme, they increase the levels of these neurotransmitters available for release. Now, MAOIs are very effective, sometimes for depression that hasn't responded to other treatments, but they come with major risks and require huge lifestyle changes. This is a massive NCLEX topic and patient safety priority. The enzyme MAO also breaks down tyramine, an amino acid found in certain foods. If a patient on an MAOI eats foods high in tyramine, things like aged cheeses, cured meats, pepperoni, salami, fermented foods, sauerkraut, soy sauce, and beers, and red wines, the tyramine doesn't get broken down. It builds up and can trigger a potentially fatal hypertensive crisis, a sudden severe spike in blood pressure.
Wow, so that diet restriction is absolutely non-negotiable.
Absolutely non-negotiable. And it's not just food. MAOIs have dangerous interactions with many other medications, including common cold medicines, other antidepressants, and certain pain relievers. As a nurse, your teaching role here is paramount. You need to provide extremely clear, detailed written lists of forbidden foods and drugs and reinforce this constantly. Patient adherence is literally a matter of life and death.
That's incredibly important. Okay, shifting gears now to mood stabilizers, mainly for bipolar disorder.
Right, for bipolar disorder, the classic mood stabilizer is lithium. It's been used for decades. We don't fully understand its exact mechanism, but we know it affects electrical conductivity in neurons and influences various neurotransmitter systems, helping to level out those extreme mood swings. Now, the critical point for nurses with lithium is its low therapeutic index.
Meaning the effective dose and the toxic dose are really close together.
Exactly. There's a narrow window between getting a therapeutic effect and getting serious toxicity. This necessitates regular monitoring of blood lithium levels. It's absolutely essential. You need to teach patients and watch for signs of toxicity, which can range from mild things like fine tremor, nausea, thirst, and polyuria, increased urination at lower toxic levels, to severe symptoms like coarse tremor, confusions, seizures, arrhythmias, and even coma or death at higher levels. Table 3.3 in your text usually lays these out really clearly. You also need to monitor kidney and thyroid function, as lithium can affect both over time. And hydration and sodium balance are key. Dehydration can quickly lead to toxic levels. Besides lithium, several anticonvulsant drugs are also used as mood stabilizers. Valproate, Becody, carbamazepine, Tegretol, lamotrigine, Lamictal. These work generally by stabilizing neuronal membranes, making neurons less likely to fire excessively. And remember our pharmacogenetics point. With carbamazepine, there's that crucial FDA recommendation regarding the HLA-B2551-2 allele testing in patients of Asian descent due to the Stevens-Johnson syndrome risk, right? The SJS risk with carbamazepine. Yes. And for these anticonvulsants, you'll typically be monitoring things like liver function tests and complete blood counts, as they can sometimes affect the liver or blood cell production. Lamotrigine also has a risk of serious rash, so patients need to be taught to report any new rash immediately.
Okay, mood stabilizers covered. Let's move on to antipsychotic drugs.
Antipsychotics are primarily used for schizophrenia and other psychotic disorders, sometimes for mania or as adjuncts in depression. They were generally divided into two main groups. First-generation antipsychotics, FGAs, also called conventional or typical antipsychotics. Examples include haloperidol, Haldol, and chlorpromazine, Thorazine. These primarily work by blocking dopamine D2 receptors quite strongly. Remember we said schizophrenia is associated with excess dopamine. FGAs target that directly. They're often very effective for the positive symptoms of schizophrenia, things like delusions, hallucinations, disorganized thinking.
But they come with those movement side effects, right? EPS.
Yes, that's the major downside of the strong D2 blockade. Extrapyramidal symptoms, or EPS. Because dopamine is also vital for smooth, coordinated movement, blocking it can cause movement abnormalities. These include acute dystonia, sudden, painful muscle spasms, often of the neck or eyes. Parkinsonism symptoms mimicking Parkinson's disease, like tremor, rigidity, slow movement, bradykinesia. Akathisia, a really unpleasant feeling of inner restlessness and inability to sit still. And the most concerning one long-term is tardive dyskinesia, TD, involuntary repetitive movements, often of the face, tongue, lips, or limbs, which can sometimes be irreversible even after stopping the drug. As a nurse, you absolutely need to be vigilant in assessing for EPS. Using standardized tools like the Abnormal Involuntary Movement Scale, or AIMS test, regularly is key for early detection, especially of TD. FGAs can also cause other side effects like hyperprolactinemia due to dopamine's role in inhibiting prolactin, anticholinergic effects, orthostatic hypotension, sedation, and weight gain. Then we have the second-generation antipsychotics, SGAs, also called atypical antipsychotics. Examples include clozapine, Clozaril, risperidone, olanzapine, Cyprexa, Crestupine, Seroquel, Ziprasidone, Geodone, aripiprazole, Belotazine. These generally have a lower risk of causing EPS compared to SGAs. Why? Because they tend to block D2 receptors less intensely and also affect other neurotransmitter systems, particularly serotonin receptors, specifically 5-HT2A antagonism. This broader receptor profile is thought to help mitigate the motor side effects and also makes them potentially better at treating the negative symptoms of schizophrenia, things like apathy, lack of motivation, social withdrawal, which FGAs don't help as much with. However, SGAs come with their own set of significant risks, particularly metabolic syndrome.
Metabolic syndrome, that's weight gain, blood sugar issues.
Exactly. Many SGAs, especially clozapine and olanzapine, carry a significant risk of causing substantial weight gain, increasing blood glucose levels, potentially leading to type 2 diabetes, and elevating lipid levels, cholesterol and triglycerides. This is a huge patient teaching point and requires ongoing monitoring of weight, waist circumference, blood pressure, fasting glucose, and lipid panels. You need to collaborate with patients on diet and exercise strategies. And some specific SGAs have unique critical risks you must know. Clozapine, while often the most effective antipsychotic, especially for treatment-resistant schizophrenia, has a potentially fatal risk of a granulocytosis.
A granulocytosis, that's a severe drop in white blood cells.
Yes, specifically neutrophils. It leaves the patient highly vulnerable to infections. Because of this risk, patients on clozapine require mandatory, regular monitoring of their absolute neutrophil count, ANC, through blood tests, often weekly at first. There are strict protocols around this. Risperidone among the SGAs has a relatively higher risk of causing EPS, especially at higher doses, and can also significantly increase prolactin levels. Olanzapine has one of the highest risks for weight gain and metabolic issues. Aripiprazole is a bit different. It's sometimes called a dopamine system stabilizer or partial agonist. It acts like a dimmer switch, partially blocking dopamine where there's too much, but potentially boosting it slightly where there's too little. It generally has a lower risk of metabolic issues, but can sometimes cause akathisia.
Lots to keep track of there. Okay, quickly, what about drug treatment for ADHD?
Right, attention deficit hyperactivity disorder. Paradoxically, the main treatments are psychostimulants, drugs like methylphenidate, Ritalin, Concerta, and amphetamines, Adderall, Vlans. It seems counterintuitive to give stimulants for hyperactivity, right? But in individuals with ADHD, these drugs are thought to work by blocking the reuptake of norepinephrine and dopamine, particularly in the prefrontal cortex. This actually helps improve focus, attention, and impulse control, leading to less hyperactivity and distractibility. However, they do have side effects like insomnia, decreased appetite, potential for agitation or anxiety, and they can increase heart rate and blood pressure. There's also a potential for misuse or abuse, so they are controlled substances. There are also non-stimulant options like atomoxetine, Strattera, which is a norepinephrine reuptake inhibitor. It avoids the abuse potential but might be less effective for some, and requires monitoring for potential liver issues and cardiovascular effects.
Okay. And finally, drug treatment for Alzheimer's disease. What helps with the memory loss?
For the cognitive symptoms, primarily memory loss, in Alzheimer's, the mainstays are cholinesterase inhibitors. Drugs like donepezil, Aricept, rivastigmine, Exelon, galantamine, Rezidine. They work by inhibiting the enzyme acetylcholinesterase, which normally breaks down acetylcholine. Acetylcholine is a neurotransmitter that's really crucial for learning and memory, and its levels are known to be depleted in Alzheimer's. By blocking the enzyme, these drugs increase the amount of acetylcholine available in the synapse, hopefully boosting cognitive function or at least slowing its decline. Common side effects are often GI-related, like nausea or diarrhea. Another drug used, often in moderate to severe stages, is memantine, Namenda. It works differently by blocking NMDA receptors for glutamate. Excess glutamate activity can be toxic to neurons, excitotoxicity, and memantine helps protect against that damage. These two classes, cholinesterase inhibitors and memantine, target different aspects of the disease process and can often be used together. And just before we wrap up, I really want to circle back to something crucial for you as nursing students: herbal treatments.
Oh, right. Things patients might take that aren't prescribed.
Exactly. And many patients have this belief that because something is natural, it must be safe. This is a really critical misconception you need to address. Many herbal remedies can be ineffective, or worse, actively dangerous, especially when they're combined with prescription medications or other substances. For example, St. John's wort, sometimes used for depression, can induce those CYP enzymes in the liver, potentially making other medications less effective. It can also contribute to serotonin syndrome if combined with SSRIs. Ginkgo biloba can increase bleeding risk, which is dangerous if someone is also taking warfarin or aspirin. Kava, sometimes used for anxiety, carries a risk of serious liver damage, hepatotoxicity. So, the bottom line for you as a nurse is, you must always ask specifically about the use of any herbal products, vitamins, or supplements as part of your medication reconciliation.
Don't just ask about prescription meds.
Precisely. Ask directly, using open-ended questions. Are you taking any herbal remedies, vitamins, or over-the-counter supplements? Many patients won't think to mention them otherwise. Assessing this is absolutely vital for holistic, patient-centered care and, fundamentally, for patient safety.
Wow. That was truly a deep dive into a really complex but obviously so important world of psychobiology and psychopharmacology. It's just so clear that understanding this delicate brain balance and how these medications interact with it, it isn't just academic stuff. It's absolutely fundamental to nursing practice.
It really is. And, this knowledge, it's not just about getting through your exam, so it will help with that. It's about building that profound understanding that lets you provide the safest care, the most effective care, and truly patient-centered care. When you really get the mechanisms, when you can anticipate the potential side effects, when you know what needs monitoring, that's when you can truly advocate for your patients. You can educate them effectively, build trust, and really empower them to be partners in their own treatment and recovery.
So as you all continue your studies, just remember, every single concept we touched on today, it connects directly to your future role. It connects to the real people you'll be helping. It's really about weaving together that precise scientific knowledge with genuine, profound empathy.
Absolutely. Keep asking those questions. Keep digging deeper. Don't be afraid of the complexity. You are building not just a knowledge base, but the critical thinking skills and the deep understanding that will make you truly exceptional mental health professionals.
From the entire Last Minute Lecture team, thank you so much for joining us on this deep dive. You really have got this.